Providence Grand Rounds. My name is Jesse Powell, and I'm pleased to welcome you all here today. I want to give a quick heads up that next week we're going to have Dr. Zemsky speaking about AFib. And today it's my great pleasure to introduce our very own Chris Bender as our speaker. He is currently our chief resident, wrapping up a very successful chief residency year here at Providence, Portland. Chris is an Oregon native. He went to the University of Texas Southwestern Medical Center for his medical school, where he graduated with distinction in quality improvement. During his residency, he's worked on expanding the use of buprenorphine, which work he presented at the National ACP meeting in 2022. And he's helped oversee the implementation of a new quality improvement elective for our residency. He also is a ringer on the Providence Hood to Coast relay team. I can speak from personal experience. And after completing his chief year, he's going to be working as a hospitalist at Legacy Emmanuel and Good Samaritan. And we're so happy he's here to talk to us about leadership in medicine. Dr. Bender.
Awesome. Well, thanks for that introduction, Jesse, and thank you all for joining me this morning. So in preparing for this talk, I kind of reflected on what I've learned in the past year, and I didn't feel like after 1 year of being an attending, I was a content expert in any specific medical topic, but did certainly feel like I had a lot of opportunity to witness and experience leadership skills over the course of this year, both in the people I've worked with and the chance I had to step into this role. So I thought this talk would be a great opportunity to dig in a little bit more on what those skills are and what makes a good leader. I think particularly, my training experience going through the pandemic, I firsthand saw the importance of good leadership in our healthcare systems as it adapts to new challenges and has continued changing. But really for this talk, what I wanted to focus on was more how those leadership skills apply to us every day in clinical practice. So when I talk about leadership, I kind of wonder what do you all think of when I talk about leadership in medicine? I think most people tend to think of our CEOs, program directors, other title positions in a way that tends to dichotomize us into leaders and others. And I think that term leadership is just associated with the baggage of these titles and offices that are really just a subset of the physician community. I think further that this is perpetuated a bit by the structure of our medical education system, which doesn't really prioritize leadership skills as one of the core competencies of a physician. It doesn't necessarily have a large volume of direct didactic instruction on how to be a leader. Instead, we rely on our trainees to pick up these skills on their own through observation and inference. And of course, leadership is certainly valued in our healthcare systems and training, but I think we could do a better job of actually teaching our residents and medical students on how to be leaders. And so today what I'd like to do is convince you otherwise, as far as leadership being a subset of physicians and people in the medical community and something that we all can practice on a daily basis. So why should you care about leadership? First of all, I'd encourage you all to think of yourselves as leaders for your patients. Our role as physicians naturally puts us in the place where we are seen as leaders by our patients. And so acquiring the skills and techniques that make a good leader will help you to better take care of your patients, whatever setting that may be in, whether that's in the hospital or in the clinic. And along the way, it'll also help give you some skills to change our systems for the better. I think that as our healthcare systems grow in size and complexity, as teams get bigger, those leadership skills will only become more and more important for physicians in coordinating the delivery of care. So what I would encourage you to think of these leadership skills as an essential part of your toolkit in patient care, just like you would your knowledge of pharmacology, your ability to build a differential diagnosis, or your competence in performing basic procedures. So for our talk today, and as a caveat, this will primarily be aimed at physicians and advanced practice providers who do practice as the team leaders in the inpatient setting, and that's mostly what we'll focus on is my area of future practice. But these principles will be broadly applicable to all those who work in healthcare, from support staff to nursing staff to everyone who's involved in caring for our patients. So our learning objectives for today. First of all, we're going to identify key leadership attributes that can help to improve care at the bedside, including specifically the team steps model. So again, like I said, we're going to be focusing on inpatient care and primarily direct patient care. We're going to discuss some of the barriers that make leadership difficult in a hospital setting, and there are many. Then we're going to review what the state of the current literature is that examines leadership and patient outcomes. And then we're going to practice a little bit applying some of these principles in real healthcare scenarios. Okay, so what skills make a good leader in the hospital? This is by no means a comprehensive list, but a list of some of the traits that I put together based on both my experience and some resources, which we'll discuss here soon. So the list that I put together is number 1, communication, number 2, critical thinking and foresight, number 3, situational and social awareness, number 4, role modeling, and then number 5, responsibility. And we'll go through all those in a bit more in detail here soon. But before we talk about those, I also wanted to introduce the team steps model, which some of you may already be familiar with. But so what this is a teamwork system which was developed by some government agencies with the goal of improving healthcare outcomes and safety and communication. It is an open source free use curriculum that any healthcare system can use. All the materials are available online, and I reviewed a lot of them before putting together this talk. And it identifies a few key skills, including leadership, communication, situation monitoring, and mutual support, and details how healthcare providers can practice those skills and how those skills interrelate between the team and the backgrounds that all team members are coming into the situations with. Specifically, the team steps model identifies some tools and strategies that I'm sure many of you have seen used in the hospital before, things like the SBAR format for standardized communication, along with the use of CUS language. And the team steps model uses all these tools to work towards a few different outcomes. Certainly the primary one is patient safety, but along the way, part of that is having a shared mental model between the whole team. And that's a theme that we'll be coming back to multiple times today. The idea that the more everyone on the team is on the same page of what's going on and what we should be doing and what our goal is, the better the team will perform. And also some of those attributes of team performance, just meaning that the team knows each other well, the team is achieving its goals, and can change to different to adapt to different scenarios is all part of that team function. So moving on to some of the attributes I identified. First, I wanted to talk about communication, which I think is the most important skill that we're going to discuss today, and arguably the most important attribute of a leader. We could certainly have a whole series of lectures just on this topic, but we'll go through some of the highlights here. Just first of all, for the healthcare setting and specifically the Joint Commission in reviewing Sentinel events and their first review of events between 1995 and 2005 found that 2/3 of the events that they were looking at had communication as a root cause of the event. And continually thereafter, in further analyses, communication continues to be a major contributor to adverse events in the hospital. So what is good communication? I think most of us feel like we know what it is, but to more specifically define it and using the language that the team step system uses. Good communication is complete, meaning it contains all of the important information that needs to be conveyed. It's clear, meaning it is intelligible to the target audience. It is brief, meaning that it's not going on any longer than it needs to in order to keep audience's attention and not add in any distractors. And it's timely, meaning it's delivered when it needs to be delivered and there are not significant delays in the communication of the information. There are lots of important tools that can be used for communication, but some that you're probably all familiar with are things like SBAR and closed loop communication. So SBAR, if you're not familiar, is kind of a formatted template for conveying situations in a concise format. So that's situation, background, assessment, and recommendation. So a protocolized way for a healthcare provider to quickly convey information to another. And then closed loop communication is also important communication technique in the hospital, which just means that the receiving audience is repeating back what they heard and affirming it in a way that makes it clear to everyone that they understand the communication being given, or offers an opportunity for clarification if there was a miscommunication. So some examples of good communication in the hospital. So first of all, using that closed loop communication I just identified. So an example of this would be, can you, provider saying, can you push 1 milligram of Ativan? And then the responding nurse would say, drawing up 1 milligram of Ativan as they're drawing up the medication, and then now pushing 1 milligram of Ativan. It's a great example of just a very clear, direct description of what is happening so that the whole room knows what the dose of medication is and when it is being given, and specifically the difference between when that process is started, between when that process is finished. Another example, so potentially a physician responding to an RRT or dealing with a sick patient might say something to the nurse or the rest of the care team like, I think this chest pain is unlikely to be cardiac in origin. I'm ordering an EKG and a chest x-ray. Please page me when these are complete so that I can review them. So this is a great example of a communication that concisely communicates what they think is going on, non-cardiac chest pain, gives next steps as far as workup, and EKG is a chest x-ray, and then also gives the care team a follow-up item, which is that when these are complete, to contact the provider. And then finally, another example of good communication in the hospital. I am concerned that if the patient's respiratory status does not improve with administration of Narcan, then we will need to intubate. So this is a great example of how a provider might help and reinforce a shared mental model of this patient is not doing well from a respiratory standpoint, and prepares the whole team for the next steps in contingency planning if the current plan is not successful. So the current plan is to give this medication. If respiratory status doesn't improve, that means that the respiratory therapist and the nurse can already be getting together the necessary materials for intubation as needed. Okay, so moving on to our next principle that I've identified, which is critical thinking and foresight. I think this is one that comes a lot more naturally to those of us who are trained as physicians, because it's using all the skills that we're really comfortable with and are part of our normal training. So this is where we get to shine in terms of using the base of medical knowledge that we have built up to help guide care and prioritize objectives. This is where we're synthesizing all of the important clinical information, making diagnoses or differentials, communicating that to the team, then prioritizing objective. And I think what I'd really highlight here is that a critical part of this is that we are using our medical judgment to assess what we think is going on, but we are also making sure that this is communicated effectively to the team, so that we're all operating on a shared mental model. And that occurs through a combination of different methods. One of those can just be documentation of the chart. Having good, clear chart documentation will get everyone on the same page before we all meet in the same room. Verbal communication, so after you're seeing your patient each day, finding the nurse and saying, this is what's going on, this is my plan for the day. And our nonverbal communication as well, so our actions, both with how we're seeing the patients, when we prioritize seeing them in the day, and how we act based on what we've decided is important. Because our nurses and the rest of the care team will take cues based on what we do, not just what we say. And so being skilled in this area requires competence in medical reasoning, clinical decision-making, and knowledge of hospital systems. Next up, I want to talk about situational and social awareness, which may seem like two separate things, but I think they're pretty closely linked. And what this is having an advanced level of knowledge of how both the systems that you work in and the people you work with operate, and then applying this to a specific situation. So the Team Steps model uses this STEP tool for what they call situation monitoring, which is just kind of the idea of keeping up to date on an active patient situation, which could be something more acute like an RRT or a code blue. But the same principles can be applied in kind of more generalized situations like discharge planning and day-to-day patient care. And so this STEP tool identifies kind of 4 components of situation monitoring. The first is the status of the patient. So this is the history of how they got here, what their diagnosis is, what their current vital signs are, what medications they're getting, what their exam is, all the basic things we think of, and detailing what's going on with the patient for the day. Next up, identifying team members. So this is who you're working with, who's involved in the patient's care. This means thinking about, are all the team members I want physically present in the room if we're dealing with something like an RT or a code blue? And are they all equipped to do the jobs they're currently doing? Do they have the skill and background training to do that job? And are they having any issues with fatigue or stress where they're not able to perform at the level they might usually need to? Next up, think about environment. So this encapsulates kind of more broad esoteric ideas like the facility and administration and setting that you're working in, as well as the more concrete ideas of what's the physical space of the room that I'm working in? Do we have the equipment we need at the bedside? Is there anything I need the nurse or support staff member to go grab while I'm here, like the non-invasive ventilation machine or something like that? And then progress towards goals. So just also highlighting the idea that as the leader, you should be continually circling back to what is the goal we're working towards, which something like code blue could be as simple as just ROSC, or might be something more complex. And are the things we're doing working towards that goal? Do we need to reevaluate how we're progressing towards the goal or what our goal is? And so just highlight here a knowledge of how hospital systems operate and the people you're working with is critical to progressing your team towards its goal. Another thing I'd highlight is that really helps to be familiar with the team members you're working with and their respective roles and skills. But in the big hospital environment, often we are working with new people every day. And so good, clear, brief introductions are really helpful and often necessary. So just briefly saying your name and what your role is in caring for the patient can go a long way and prompt others to do the same. And don't be afraid to ask if you're just uncertain who everyone is. Okay. So next up, I wanted to talk about what I'll call role modeling, which I think is a crucially important skill as a leader. I think we generally underestimate the authority that we carry just by walking into the room as a physician, and the way that we're not just listened to, but also observed in the way we behave with patients. So what I'd highlight is that the way we interact with our patients will shape the team's attitudes towards their care. This is a really important opportunity to reduce bias against disadvantaged or marginalized populations, whether that be patients with history of IV drug use or patients who are part of historically marginalized populations. Us as the team leader showing that we care about that patient and treating them with dignity and respect will go a long way to the rest of the care team doing the same. And conversely, if we're jaded and not showing our patients the respect they deserve, the rest of the care team may follow that as well. I'd note also kind of in the same theme of role modeling that strong leaders are familiar with the tasks that the rest of the team are performing and provide direct feedback and instruction when necessary. So that is certainly very applicable in my world of medical education when you're working with trainees who are performing the same job as you. Really important to be giving them that feedback and instruction on what they did well as what could be improved on or things to work on for next time. But also stepping back from the education setting in general, I think that physicians need to be as familiar as they can be with the tasks that the nurses are performing, that the respiratory therapists are performing, not so much to give feedback, but so that they can step in and help out and show that they acknowledge these are important skills. So just having a little bit of basic skills, such as knowing how to move a patient with a draw sheet, knowing a little bit of basics on how IV lines are managed and how the infusion pump works, and being able to help out with that bedside nurse when you're in there, will show a commitment to the shared goals that you have as far as caring for the patient, and signals that you understand the importance of the role of the people that you're working with. And then so last of our kind of core leadership skills I wanted to talk about is what I call responsibility. That's a pretty broad idea that encompasses a lot of different things. But kind of what I'm meaning here is that as team leaders, we end up being the face of care for our patients, and we take responsibility for any errors or mistakes, regardless of whether they occur at the individual level, the team level, or the system level. Which is just about acknowledging that we are the ones who are interacting with our patients, and when things go wrong, we're obligated to explain why, and in objective but clear terms. Additionally, this idea of responsibility, I think, means that you're not just prioritizing your own job, but you're prioritizing team performance and growth. And a big part of that is delivery of specific actionable feedback, as well as setting aside time to debrief when appropriate, such as after a code or an RRT. And again, I'd highlight feedback, both positive and negative. Positive feedback is really important to show other team members that you appreciate the role they're playing, and to help reinforce when they're doing things well, but also making sure to identify if there are areas for improvement, that you're giving that feedback in a respectful but clear way. Then I think also responsibility as the team leader means that you're kind of the first one in line to take a step back and rethink when things aren't working or fitting together. And that can be from a diagnostic perspective. If it seems like what we all think is going on is not, we need to adjust our shared mental model, or from a management perspective, just saying what we're doing isn't working and we need to be doing something else. And that's where the rest of the care team is going to be taking direction from you. So before we move on, I just want to take a pause and acknowledge the challenges of being a leader in the hospital environment, or to identify them and be aware of them, not necessarily to offer specific solutions, because there may not be a lot of great specific solutions to all of these things. So first of all, I touched on this before, but just we work in big teams with frequent turnover. Our hospitalists are often turning over every 5 days or so, and similarly with nursing staff, case managers, and everyone else we work with pretty much every day in the hospital. You usually end up working with at least one new person, especially if you're newer to an institution. Certainly people who've been around longer may be lucky enough to have more of those genuine connections and familiarity with the people they're working with, but that is more the exception than the rule in the hospital setting. And then I'd also highlight physical separation of the different team members. So our physicians generally work in different areas of the hospital, and may have limited passing face-to-face interaction with direct care nurses, who have their own work setting. We all come from different training backgrounds, in different professions, and we are trained to do different things, have different background information. We're making assessments and coming up with what's going on, and that can be a limiting factor in developing that shared mental model. And we all have different management who's telling us to prioritize different things, or our case managers may be focused most on time to discharge and decreasing length of stay, whereas our nursing units may be most prioritizing patient safety, things like limiting falls, and physicians certainly have their own management pressures for different priorities. And then just lastly, I'd also note that everyone's wearing scrubs in the hospital. It can often be hard to tell who's who if you haven't met people and don't know their roles. Certainly things like the titles we have under our badges can be helpful, but you're not always going to see those. So just reinforcing the importance of clear and brief, respectful introductions. Just and if you don't know someone's role, don't be afraid to just ask. It's super helpful. Just, oh, are you the direct care nurse for this patient? That can help to increase familiarity. Okay, so I just gave you a lot of value statements about what I think makes a good leader and about what some of our institutions think is important in leadership. But I think it's fair for all of you, as any good physician would, to ask, what is the evidence for all of this, and does this really matter? So next up, I put together a series of trials and studies that I think best address the effects of leadership at the bedside that we'll go through here. So first of all, I want to start with a study looking at cardiac arrest. This is definitely an area where a lot of our team sciences have been focused, both because of the importance in team principles in the process, and of course the ease of measuring direct outcomes. Cardiac arrest has the binary of did you achieve ROSC or not, but then also has a lot of discrete things to look at, such as time to first compression, time off of compression, administration of correct medications according to the algorithm. So this was a randomized controlled trial from 2009, which was performed at actually a workshop in Switzerland. And so they took 100 teams of 3 of either general practitioners or hospital physicians, and compared performance in a simulated cardiac arrest for preformed teams versus ad hoc teams. And so how they defined those teams was that preformed teams were 3 physicians together who received a scenario briefing all at the same time. So they came in having received the information, knowing the same thing, and jumped into the same scenario. Whereas the quote unquote ad hoc teams had 1 physician receiving the information for the scenario, with the other 2 physicians joining after. And so they looked at CPR outcomes as far as the process. This was a simulation. And so what they found was the ad hoc teams had significantly less hands-on time during the first 3 minutes of arrest. They had a delayed time to first defibrillation, and they made less leadership style statements. So not overall a particularly surprising outcome that the teams that received all the information together did better during CPR, but it is really strong evidence for the importance of this shared mental model that we discussed before. It's not necessarily a specific intervention that we can implement in our hospitals. Of course, we'd all love to come to Code Blue knowing all the information beforehand, but I think we all know in the real world that information ends up being messy. So really what I would take away from the study is the importance of sharing information in a clear way so that everyone is on the same page, which is, of course, easier said than done in the setting of a cardiac arrest. Next up, I wanted to discuss this study, which specifically uses the Team Steps framework that we discussed earlier. And it's one of the studies that's cited in the Team Steps curriculum. So this was done at an academic level 1 trauma center, and they evaluated their trauma team on both teamwork metrics using the Team Steps model, as well as trauma-related outcomes before and after an intervention, which was simulation-based Team Steps training. So they took a convenient sample of 33 trauma events before the intervention, and then 40 trauma events after the intervention. And what they found was that the outcomes they looked at was team functioning skills were better across all domains in those after intervention traumas. And they also found significant decreases in time to the CT scanner in trauma events of about 4 minutes, time to intubation of about 3.5 minutes, and then also a significant trend down in time to OR of about 35 minutes. So some really important, clear changes in at least patient process outcomes. They did not show significant differences in their endpoint patient outcomes, which were rate of complications and rate of survival to discharge. But there were non-significant trends towards those outcomes, with p-values of 0.11 and 0.12 favoring after the intervention. Now, I think, again, like all the studies we're going to discuss today, this definitely has some significant limitations. I think the study's biggest limitation is the lack of a clear control group. They're comparing to the pre-intervention group. This is happening on timeline of academic center, which means that, of course, residents are getting more skilled and better at their jobs as the year goes on. And that certainly is an opportunity for confounding in the study, but nonetheless, certainly one that supports the ideas that we're discussing today. So next up, I wanted to discuss this study, which I think is a really cool study, but one that was limited in its implementation due to the COVID pandemic, unfortunately. So this was a 12-month randomized controlled trial at a large academic inpatient medical center. And so what they did was they essentially took the entire intern class, other than a small number who opted out, and randomized the interns to complete either all of their medicine wards rotations, which was 16 weeks worth, on one medical nursing floor, meaning they had all their patients seen on the same floor, they had continuity with those providers, versus the control group was the normal system where their teams saw patients all over on 4 different floors. They didn't have any specific continuity with a specific group of nurses. And with this cohort, they had the team with the nurses they were working with complete simulation scenarios at a timeline of first 6 and then 12 months. And during the scenarios, they were assessed on interprofessional communication, psychological safety, and teamwork culture. Then they were also surveyed on those attributes at 6 and 12 months as well. So what they found was that at the simulation, at 12 months, the intervention team scored higher in leadership and management skills and were more likely to use one unit. They were more likely to negotiate with the patient, support their team members, and communicate as a team. And they were also more successful in achieving the correct simulation outcome compared to the group that did not have as much continuity with nurses. As far as the subjective assessments of the group, there were significant differences in the survey at 6 months, and nurses from the intervention group felt they had better relationship with residents, felt their input was more valued, and felt that feedback was delivered positively. Interestingly, the survey outcomes actually became insignificant at 12 months. There were no significant differences, but very important to note that 12 months into the study was June of 2020, and so there was interruptions in the implementation of this intervention, and of course was just a quite abnormal time in healthcare to be getting anyone's opinions on anything. But overall, I think this study is an interesting one as far as showing the importance of continuity. One that's certainly difficult. I think certainly going through my residency training, I can empathize with that we are working with different people all the time, and it is really tough to have continuity with the staff of the hospital because of that. So not necessarily this specific intervention is one that's going to be implemented everywhere, but more that the concept of anything we can do to increase familiarity with our support staff, nursing staff, and the physician teams is as important for patient care. Okay, next up is a trial from the Journal of Hospital Medicine. And so this study examined a bundle of 8 different interprofessional collaboration interventions at a large medical center. I think this paper has inspired a lot of interventions at our local hospitals here, as well as all over. And so those 8 interventions that were implemented all at once were: 1, geographical cohorting of patients and providers. So having a provider team be all patients in the same floor or area of the hospital. Bedside collaborative rounding. So physicians seeing patients and the care team at the same time to discuss things like discharge barriers and discharge planning. A daily huddle of the support staff to identify which patients are close to discharge, or other important care aspects. Hospitalist and specialty co-management agreements, so kind of having specified ahead of time what aspects of patient care the hospital's team versus the subspecialist might be managing, such as, common issues we deal with like hip fracture or something like that. The use of a unit whiteboard for discharge planning. So just having the same information visually available to everyone in the same place. And then a process of monthly review of unit level data to see how they're doing on readmissions and length of stay. Weekly patient satisfaction rounding, so to make sure that our patients' needs are met. And then having assigned year-long unit leaders from the physician team who are in charge of kind of overseeing all these implementations. So what did they find in the study? So I think that the way they measured the study was interesting and done well. So they looked at measurements of length of stay, a complex estimate of cost of hospitalization and patient satisfaction and provider satisfaction. But rather than just looking at pre and post intervention, they actually scored adherence to the interventions and compared outcomes to that. And so what they found is they did find a statistically significant decrease in length of stay and estimated costs of hospitalization over the course of intervention. And these outcomes were directly correlated with higher intervention adherence scores. So not just a change in time, but a change associated with the specific interventions. And while they did not find a significant difference in patient satisfaction, they did find a significant difference in provider satisfaction. Providers generally agreed that the interventions improved quality, safety, communication, efficiency, and job satisfaction, which is, I think, a really big achievement here with, adding a lot of work for people as far as all these interventions and actually getting a positive response from providers. Okay, next up, I want to talk about a cool study that was done actually from my medical school, UT Southwestern. So this one, again, used the TeamSteps framework, specifically using validated teamwork perceptions questionnaire, and was done before and after a remodel of the emergency department. So no control group here, or a time-based control group, I guess I could say, of before and after. They were using the same group of 46 staff members. And so what they did was, in remodeling the emergency room, they moved to a pod-based model. So you can see before here, the nursing stations highlighted in blue were separated from the provider stations highlighted in red. I think this is a pretty traditional hospital layout model, which we're all used to and familiar with, which is that the physicians work in one area, support staff works in another. And I think it certainly can limit the amount of direct communication we have and kind of reinforce the idea of us being different teams, different worlds. And so after the remodel, they instead had these provider care stations highlighted in blue here, which were mixed workstations, including both physicians and nurses. And both physicians and nurses surveyed showed significant improvement in team structure, situation monitoring, mutual support, and communication. So higher skills on all those important teamwork skills through a physical redesign of the space. And so again, certainly not easy to immediately change our physical spaces, but I think brings forward an important concept as we continue to redesign our healthcare systems and think how we can make care better for patients. The next study I wanted to look at and discuss is the one that has the largest data set of any of those that I'll discuss today. So this was actually a secondary analysis of data collected from 27 different VA medical centers on patients admitted for stroke rehabilitation. So during the original trial, they collected some measures of team functioning. So this secondary analysis took those measures and directly correlated them with patient outcomes, specifically looking at length of stay and rates of community discharge. And what they found was physician engagement with the team correlated with a decreased length of stay, and scores of teamness and team effectiveness were correlated with higher rates of community discharge. So not an intervention type trial, but just another one that shows that link between team functioning and better outcomes for our patients. Another interesting study here, which is a little bit more adjacent to some of the core topics we've been discussing, but that I thought would be fun to include, is this one that looked at applying what they call athletic principles to medical rounds to improve teaching and patient care. And so this was a pilot study of general medicine rounding teams, and they had compared an intervention group to a control group. In the intervention group, they use what they call an athletics inspired model, which was using quote unquote playbooks and film review to work on making the team perform better. What they really mean by that was those playbooks were kind of detailed descriptions of each provider's role in patient care, as well as understanding what other providers' roles were. And then film review is this idea of having the PI for the study, observe the team weekly and making suggestions on how the team could perform better. So things like making sure all the team members are included in the daily huddle, and encouraging the attending to ask guiding questions to the group rather than dominate in conversation. And they showed some pretty dramatic outcomes, which was a 30% reduction in 30-day readmissions and an 18% shorter length of stay compared to the control groups. Surveys showed improved satisfaction among all the team members. And so while certainly not a perfectly designed trial, kind of a good example of the Hawthorne effect, where us looking and emphasizing something made it work better. But I think a great example of how, from a QI perspective, we can think about improving both outcomes and teamwork in our own hospitals, not necessarily a study that's quite so generalizable as an intervention. Okay. And then finally, the last study I wanted to highlight is one that looked at physician team management in a pediatric intensive care unit. So this was a cohort study done at a single center pediatric ICU, and they surveyed residents and fellows on this physician management index that you can see here on the right of the slide, looking at a bunch of different leadership skills, all which kind of fit with things that we've talked about today, along with some others. And they compared them to the primary outcome of completion of daily care goals. So they had kind of for each patient, discrete list of care goals and looked at the binary of how many goals were completed or not. And so first of all, what they found in the study was that inter-rater reliability of the PMI for each attending was high. So there was general consensus along which attendings might have been stronger leaders or have deficiencies in some of these leadership aspects, and that the attendings with higher PMI scores were correlated with the achievement of more daily goals. Also, just a fun thing to note in the study, achievement of goals was also highly correlated with a shorter length of rounds. So to any of you who work in the medical education setting, maybe think about keeping an eye on the clock during rounds and making sure your residents have time to get their tasks done. So to pause here and talk about the summary of the data we've reviewed. So number one, the effect of bedside leadership is an active area of research, a lot of interesting studies being done in this area. In general, study design is difficult with these studies. There is no simple leader placebo to compare interventions to. Generally, not having a team leader is not going to be a study that gets approved by an IRB. And a lot of these studies are single center studies. Many rely on simulation because of the difficulty of designing trials with interventions and the complexity of generalizing interventions to multiple different centers. But overall, all the data here shows promising trends that link leadership qualities and leadership interventions with both process and endpoint outcomes for our patients. And also think about making your round shorter if you are an attending on the teaching service. Okay, so next up, I wanted to take the opportunity to apply some of the principles we've been talking about in some patient cases that all come from my clinical experience, mostly pretty recent clinical experience. So the first case I want to talk about was a complicated code blue, which I encountered during my third resident year working in the ICU. So this is a 68-year-old guy. He was on post-op day 3 after a complex vascular surgery with revascularization, stenting, grafting. He was on the floor, had a code blue called after nursing first noted torsade de pont on his telemetry. When they went to bedside, they found him unarousable and pulseless and called code blue. We responded to the team. We arrived as third-year resident. The ICU attending there looked at me and found the code leader sticker from the code blue kit and put that on my badge and put me firmly in the role of code leader, which was a really experience, and I would say probably my most memorable experience being code leader as a resident. In this case, just ended up being really complicated with a sick patient and a lot of difficulty palpating pulses, which of course is, if you're all familiar with our ACLS algorithm, if you are having difficulty determining if there's a pulse or not, that's really going to make the case more difficult. And so because of both this patient's extensive vascular disease, as well as the surgical wounds, we ended up shifting to having the intensivist use an ultrasound Doppler to check the femoral pulse. Additional complicating factors here, this room was very small. And so while we had the Lucas device come, if you're not familiar, this is an auto compressing device, which can take over the role of a chest compressor. But because we had so many people in the room and limited space to try and get the device on, we actually sent it away because we did not want to have that delay in risk of compressions, or that risk of delay in compressions. So this code went on for about 30 minutes. We had a team of 3 compressors rotating out. It evolved from initially polymorphic VTAC to PEA arrest. After 30 minutes, we did get return of spontaneous circulation. And on awakening the next day, the patient was actually neurologically intact, which is, of course, very reassuring for the quality of our CPR. So the learning points I wanted to highlight from this case, and certainly you could use any code blue would be a great opportunity to talk about a lot of these, but I thought this code blue in particular had quite a few. So first, I just highlight that acute emergent situations require a clear chain of command and designated roles, and that's why we all get the ACLS training that is so clear as far as specifying specific roles. And I'd really highlight the importance of using visual cues to reinforce these roles. So I was not aware until this day during this code that our kits did include these stickers, but all of our kits have this code leader badge. It doesn't look exactly like this one here, but that is a great opportunity to clearly identify a code leader, which is also helpful for reducing implicit bias. Certainly, if the responding resident is a member of a group that has not traditionally been in positions of authority and maybe is not going to be obviously as looked to as code leader, this makes it clear for everyone in the room who the code leader is, which helps clarify communication. Secondly, as code leader, getting input from all the team members here was really helpful. Generally, when responding to a code, as you all know, kind of information can be difficult and tough to come by. And so we didn't know that they'd been in this rhythm when we showed up, but someone passed on this information that they were in Torsades, suggested IV magnesium, which we went ahead and pushed at that point, which may have contributed to our success. And then utilizing team members' unique skills. So me being code leader, which is a pretty simple algorithmic process, freed up the intensivists to use their bedside ultrasound skills to detect a femoral pulse and finally find when we had achieved ROSC. So using the STEP model for situation monitoring that we discussed, look in this case. So first, status of the patient, of course, dead as in any code blue, but more specifically, polymorphic VTAC or Torsades was really important, getting everyone on the same page of what the rhythm we were treating was, which also helped with our interventions. And then, of course, that did progress to PEA arrest. Team members involved. So first of all, identifying a core team of compressors, which did end up being 3 different compressors changing out, making sure there were enough changing out that they were avoiding fatigue during a long code, and then as well as utilizing the skills of team members such as ultrasound. Environment, for those who know the PPMC facility, we were way in the corner of 2R, and so we're working with a really small room, which made using the Lucas a bad option, and meant we had to kind of limit the number of team members that were present in the room. And then thinking about progress towards goal. So luckily ACLS kind of adds in automatic monitoring of process with routine pulse checks. But along with that, we had the primary surgeon responded as well. And so in conferring with the intensivist and surgeon, we were kind of able to confer about when it was appropriate to continue the code. Certainly, as we were getting towards the end, we had exhausted a lot of our potential interventions, and we're kind of at that point of wondering whether it was appropriate to continue CPR. Luckily, we did get ROSC in this case. Okay, next case I wanted to discuss, which I've titled Stuck in Bed. So this was a case I saw with the teaching service recently. I'm sure anyone who's spent any amount of time in hospital medicine has seen similar cases. So this is a 67-year-old guy, somewhat complex medical history of schizoaffective disorder, type 2 diabetes, recurrent admissions with issues of behavioral disturbance, admitted with generalized weakness. He had been admitted to another hospital a few months ago with bad pneumonia, had been recommended for a skilled nursing facility discharge and declined, and then basically was found down at home, unable to care for himself. So he had this weakness, and really didn't have any focal findings on exam, didn't really have marked neurological weakness on our exam. His lab workup and imaging workup, including MRIs of the brain and spine, were unremarkable. He even had an LP. And so all of this did not point to any major medical diagnosis other than deconditioning. And I took over probably about 2 weeks into his care. And when I took over, looked back through all the notes, and all of them are saying hasn't gotten out of bed in weeks, and PT seeing him, and basically they report that he declines to really do anything. He's not attempting to sit up at the edge of the bed or get up out of bed or try and walk. There's no clear medical reason that he can't do any of these things, and so their recommendation is just placement for care. So in kind of taking over the team, certainly you always have the opportunity to take a step back and reevaluate, and so that's what I did here in trying to get a hold of why he wasn't willing to get out of bed. So I just really tried to spend some time with him and directly ask him, so why aren't you working with PT? What's going on? And so he says he's scared. He's scared of falling, feels like he's gonna fall. I kind of press him on this more, and he's worried that they're not gonna catch him, and try to be as reassuring as I can, and still see he's got a lot of reluctance. And so the next skill that I used was basically kind of used my role as physician and kind of the extra authority that comes with there, and just said, how about if I come back later with the physical therapist, and would you be willing to give standing a try then? And he's still kind of reluctant, but says okay. And then so I kind of taking the opportunity, then suggested, so how about, can we do that this afternoon? And he says, that seems too soon. And I said, okay, how about tomorrow? And so I got him to agree to tomorrow, to try and get out of bed. And more than that, I wrote this plan on his whiteboard so that he was visually seeing it throughout the day. The nurse saw it, and the PTs could see it. Everyone knew it was on board with the same plan for progress of care, for a plan to attempt to stand out of bed tomorrow. So myself with the resident, we spoke with the bedside RN and scheduled a time to meet at the bedside with PT and RN. We all came there at the bedside, and he was able to successfully stand up to the edge of the bed with assist, and his rehab progressed from there. A few days later, he was able to stand up multiple times. He did eventually end up with a placement at a rehab facility. But I think this case is just a great example of the importance of understanding and participating in the tasks of other members of the team and having some basic competence in those areas. So no, certainly as the physician team, we're not the experts on rehabbing patients or getting them out of bed, but just being there and being able to help shows that we think this is important, and it signaled it both to the care team as far as the nursing and physical therapists. Of course, I have no doubt that they also wanted to get this patient out of bed and saw it as important, but our physical presence there helped. And I think it helped the patient as well, communicating, this is really important. We want this for your progress. And then also, just as far as communication tools, don't forget to use that whiteboard, because we do work in separate physical spaces. And as we mentioned before, our physical face-to-face contact can be limited sometimes with the care team. The whiteboard is a great place to make sure everyone sees the same information. And as I said before, just don't underestimate the power of your presence as a physician to support the work of your team, and how much patients see that as important. Okay, and then the last case I wanted to talk about was another case that I recently worked on with the teaching service. So this was a 58-year-old woman with history of heart failure, COPD, diabetes. She came in with these kind of bizarre episodes of hemifacial spasm and tongue protrusion. There was initially some diagnostic uncertainty, concern for possible focal seizure versus a dystonic reaction. Through her first 48 hours of admission, she had EEG monitoring. Through some of these episodes, did not identify any evidence of seizure, although the EEG read did note some significant motion artifact. And so the patient, in conferring with neurology, was given this diagnosis of Mage syndrome, which I certainly was not familiar with, but is a rare focal dystonia where patients have these recurrent episodes of dystonic facial contractions, which can be pretty disabling. And so based on this diagnosis, her anti-epileptic drug was actually stopped. But after that, these episodes continued and were not getting better. We tried muscle relaxants, some of the treatments that were recommended for Mage syndrome, but she was having this worsening dysarthria, was made NPO by SLP, was just really not advancing as far as care, and things were really getting worse. Then on hospital day 5, our team was paged for an altered level of consciousness. We arrived and actually found the neurologist at bedside, luckily. And as a team, we all saw this patient progress from obtunded into a hemifacial spasm episode, and then subsequently into a grand mal seizure. And so the neurologist clearly identified that as such, communicated to the room, I'm seeing seizure activity, recommended Ativan and Keppra, which we discussed with him, and then which did successfully abort the seizure. Then the patient was still pretty obtunded, had some concerns about airway, so the senior resident astutely recommended a nasal trumpet for airway maintenance, and the patient was then transferred to the ICU. So what would I highlight in this case? First, I think just that out loud communication for a shared mental model was critical in this instance. That's the neurologist identifying the new information he's getting and adjusting the diagnostic reasoning, saying that he had witnessed a clear seizure. That gave the rest of us comfort in the room as far as proceeding with management. Our senior resident did an excellent job of communicating his concerns about airway to the room, and gave a direct recommendation of a nasal trumpet, which the rapid response nurse placed with subsequent improvement in respiratory status. And then after the suggested diagnosis of seizure, we practiced closed loop communication with the bedside RN regarding the pushing of the medication. She clearly identified to the room when the medication was given, pushing 2 milligrams of Ativan now. So we all knew that when the treatment had been given, we're ready to see if it worked as far as the seizure reporting. And then our team did have to take responsibility. While this was certainly a complex case, one that was difficult diagnostically, even though it was certainly a discussion between us and the neurologist, ultimately as the primary team, we had to talk with the family about the diagnostic error and just give an objective description of the series of events. So in summary, from what I've talked today, I'd note that effective leaders in the hospital exhibit a variety of important characteristics, which we've discussed here: communication, critical thinking and foresight, situational and social awareness, role modeling, and responsibility. The current evidence base generally supports the importance of leadership skills and teamwork, but individual studies are limited in their design and generalizability for specific interventions, which I think just really highlights the need for local experience and wisdom in leadership. And then specific real world cases often require the implementation of many of these skills at once. So just some acknowledgements in putting together this talk, and my chief here in general, want to give a big thanks to my mentors in leadership this year, our program director, Brenton Clark, the chair of our department, Scott Marsall, who've both been great examples to look up to of strong leadership in medicine, along with the rest of the PPMC medical or residency faculty. Then also a big thank you to all of the residents who put up with me practicing and learning as a leader at their expense. Then also a thank you to our librarian, Vasya, who helped me put together the sources for this presentation, which are shown here. So I'll take a pause, and I think we maybe have just a little bit of time for questions.
Yes, thank you so much, Chris, for a very compelling grand rounds. Excellently done and summarized. And we're butting right up at about 9 o'clock, but I had a couple of questions I wanted to ask you. One is, I was interested in that you quoted the Joint Commission finding a good 2/3 of Sentinel events were related to miscommunication or communication errors. And I was wondering if you knew more about that. Was that specifically these kind of problems, things that you just described, these communication styles that are meant to remedy those sort of problems, like, oh, there wasn't closed loop communication, so I misheard and thought you said 2 milligrams of epinephrine, or something like that. Was that where most of these Sentinel events were happening?
I didn't dive too in detail to a lot of that specific data, but yeah, that's my impression that a lot of this is stuff that has gotten a bit better as far as our communication practice in the hospital. But yeah, kind of simple things like missed medication dosages, kind of missed plans. I think a lot of our communication in the hospital has changed in the time since 1995. You can imagine a lot of that was before electronic medical records. A lot of things were being done in handwriting or verbally. And I think that may be why a lot of that was an even bigger source of errors than it is now.
I also liked how, I think when you mention a lot of these leadership skills, it does seem like things that are most useful in a very intense situation like a Code Blue situation. I like that you included some other examples, and I wondered if are there specific areas in the hospital where you think these leadership techniques should be implemented generally? So, for example, do you rally your team first thing in the morning and kind of discuss roles, or is there a time that do you try to spend time on the nurses station, or are there other situations where you could use these leadership techniques outside of a critical incident?
Yeah, I think just more of that face-to-face time in the hospital would be really important. It's certainly something I'm working towards in my clinical practice. I think we all know there are a lot of competing demands in the hospital, but I think something like taking a step back to how our systems are designed, or even our physical spaces are structured to encourage more of that face-to-face time. But yeah, exactly. I think I'd agree that most obviously these are important in an RT or Code Blue, but also day to day, a lot of this stuff matters, and just direct communication with everyone is really important.
And I want to note that Vasya gave you a thank you for the shout out. And I also want to plug Vasya for her excellent library work. If you have a topic you're interested in, she's great at helping you gather resources.
Absolutely.
Or keep up recurring alerts for topics you're interested in. Well, finally, Chris, I just wanted to ask, are there, I can attest that you implement a lot of these leadership skills in your day-to-day work, and really have from the beginning of your intern year since I got to know you. Based on this research that you did for this presentation, are there leadership techniques or skills that you plan to now implement or take further? What did you get most out of this presentation preparing for it?
I think definitely just using all those specific communication techniques and being very deliberate and thoughtful and identifying those. I think probably our nursing colleagues are a bit better ahead of the curve on this than we are, and maybe get better training in some of these. So being explicit and using those clear communication techniques, and then also being kind of emphasizing face-to-face time and checking in directly with the rest of the care team is stuff that I'd like to work on implementing more, for sure. I think also I'd highlight like the importance of I think simulation was actually shown to be useful in a lot of these studies. And so I know Ben Pedroja did great job of kind of beefing up our simulation curriculum here, but acknowledging that as well as an important time for trainees to get some of that experience and leadership that's not initially directly hands-on. And I think in working in medical education also, kind of identifying leadership is an important area of direct didactic instruction and feedback, because I think we don't emphasize it enough.
Well, Chris, I want to thank you for an excellent Grand Rounds. I want to thank you for a fantastic residency and chief year, and we wish you all the best in your next endeavors at Legacy and continuing this good work that you've begun here with us. And I want to thank all of you for tuning in and joining us for Grand Rounds. Please be with us next week for AFib. Have a great week.
Thanks so much, Jesse.